the JAMA Network.
I'm Dr. Tom Schwank, professor of family medicine and dean of the University of Nevada School of Medicine. I think the issue of depression in residents is a big problem, and it's a problem at two levels. We know the prevalence is high. We're pretty sure that the prevalence has increased over time, although the studies are not great in that regard. It's a problem for the residents themselves, their own personal satisfaction, their career development, their personal function, their role function at home and with their families. And it's a problem, I think, with their professional function and their performance. Not that they don't seek to perform well, but depression may significantly impair their ability to function well at work and to carry out their responsibilities. So we have both personal and professional issues at play and a very high level of prevalence. The paper by Dr. Mata and his colleagues that's in the issue of JAMA provides some really astonishing data about the prevalence of depression. For example, interview studies that are much more criteria-based gave a prevalence of actual criteria-based diagnosis of perhaps 20, 22, 24% in residents, whereas questionnaires and other instruments that are more symptom-based, either somatic symptoms or mood symptoms, gave a prevalence more in the mid-30s to low 40s. What you'd have to conclude from that is that there is an endemic of depressive symptomatology amongst our residents and fellows in the U.S. GME system. My response to that in the editorial in the same issue of JAMA basically looked at three categories or types of response that we might have to this issue. One, of course, is better mental health care, and that would make sense no matter what. So whether we do anything else in this regard, better mental health care would be appropriate. The problem, as we all know, is that there's huge levels of stigma in seeking mental health care by medical students and residents and physicians, and that impairs their ability to receive excellent mental health care and impairs their recovery. And we have worked hard on the stigma issue, but we have not necessarily made a lot of progress. A second level of response would be to limit the duty hours, to limit the stress, to try to provide more support in the training system. And of course, the ACGME has done that with their duty hours limitations that were put in place many years ago and then revised twice subsequently. The problem is that their studies are poor with regard to any significant impact, and the results are somewhat disappointing. There have been some studies that show some improvements in quality of life, but overall you'd have to say that there's no evidence of improved quality of life, possibly even a decreased quality of life for residents, and more handoffs, less communication around patient care, possibly some decrease in quality of care if we don't put other systems in place to improve handoffs, to improve communication, to improve ways that residents can share the burdens of their training. What I called for is really a third level, much bigger, much deeper, much broader, and that is to really think about a complete overhaul of the GME system. The practice of medicine has changed extraordinarily in the last 50 years. The training of residents has changed nearly not at all in that 50 years. And so we have a mismatch between the type of training that we subject residents and fellows to and the way medicine is practiced. If you just think about the extraordinary life-prolonging, life-creating technologies that we have now that create huge ethical dilemmas. Think about the rushed nature of care in the clinic and in the hospital. Think about the productivity pressures. Think about the reduced lengths of stay that limit the opportunities for learning, limit the opportunities for discussion. Think about how we have limited the opportunities for mentorship. We do not have the types of relationships that we used to have between trainees and mentors, in which some of these very profound, very difficult situations, very emotionally traumatic situations, could get processed with appropriate mentorship. And we just don't have time for that anymore. The system is so compressed and wound so tightly. So what I'm calling for is to rethink the entire approach to education and think about how educational objectives can be achieved in better balance with clinical and financial objectives. So there's a little more balance in the system, especially for residents who are buried right in the middle of an incredibly intense clinical system. We've all experienced the end result of this terrible problem, which is suicide. And those events are incredibly traumatic. Fortunately, not nearly as common as the depression prevalence itself, but it only takes one event in an educational institution to traumatize everyone, including the educational leaders. I think we just need to come together and take this on. I think we need to really make it a much bigger deal. And if we come together, especially as the Council of Deans or as a group of deans concerned about this, I think we could have an enormous impact on how these training programs are designed, especially at a time when there's huge discussion about GME in general. We know from the Institute of Medicine and other reports that there's a call for a pretty drastic and major change in how we go about GME in general, how it's funded, how it's organized. I think we should add this issue to the mix and perhaps try to solve some of those issues at the same time we're reforming the system for financial and other reasons. When you look at the pipeline of medical education and look at the prevalence of depression at various points in the pipeline, what's notable is that it's roughly the same as the general population in medical students. It's roughly the same as the general population in physicians. There's a bump during residency. I think that's a secret. I think we need to pay attention to that. There's something going on that adds some incremental burden, some incremental level of stress that we should pay more attention to. And so I think that's one of the notable contributions of this study in the issue of JAMA by Mata and his colleagues, which is it makes clear that there's something different about depression during residency than there is on either end of the pipeline, and we should pay attention to that.